This is Michael Smith of MedPage Today. I'm in Philadelphia at the annual meeting of the Infectious Diseases Society of America. Experts have reached a consensus, more or less, on how to treat and prevent H1N1 pandemic flu. But is that consensus reaching to the front lines of caregivers? My guests today don't believe so. I'm joined today by Dr. Richard Whitley. He's the president-elect of the Infectious Diseases Society and a professor of pediatric infectious diseases at the University of Alabama at Birmingham. Also with me is Dr. Arnold Monto, who is at the University of Michigan School of Public Health. Gentlemen, welcome. I said off the top that it looks as if the consensus that you people who are experts in this field have reached is not actually getting down to the front lines of the people treating patients, the people trying to prevent the disease. Dr. Whitley, you deal with children. What are the issues here?
Well, pediatricians are busy practitioners. And so while the CDC guidelines have been updated on a regular basis, that information doesn't necessarily get into the hands of the pediatricians. CDC's done a wonderful job with these webcasts that have taken place on Wednesday afternoons, usually about 3 o'clock Eastern Daylight Time. And that's exactly when the pediatricians are seeing the first blush of children coming from school, and they have to be in their office taking care of patients. So I think it's our responsibility as leaders in the field of infectious diseases to teach people how to use antivirals and to help get this message out to pediatricians.
Okay. Dr. Monto, much the same with the adult population?
Yes, I think so. And part of the problem that we're seeing is that still people don't think about a case as being H1N1 if it's in any way atypical. And then they rely to a large extent on rapid tests, and we've been trying to get the message across that the rapid tests, especially for novel H1N1, are really not sensitive. And saying that somebody is not positive doesn't mean they really aren't infected. So we've got that issue. And then we've got the issue of underusing the antivirals, especially in cases that are more severe. We've been concerned about running through the antivirals. I don't think there's any evidence that that's going to happen. So we really have to use more of the antivirals than we have been.
So we're talking here about oseltamivir, Tamiflu. The CDC and many recommendations have suggested that if you try to give the drug after 48 hours after symptom onset, you're not going to do much. But I think you both agree that's maybe an artificial barrier.
Well, it's an artificial barrier that we ourselves created because that's how we license the antiviral drugs. But if you look at the viral shedding data, and Arnold and I have spent a great deal of time studying those data, patients are still virus positive 48, 72, 96 hours later. So if you give them an antiviral drug, it's going to decrease their viral load.
And that will make them, one hopes, better.
We certainly hope so. We hope that by decreasing their viral load, we will prevent progressive disease, particularly in our high-risk patients.
Okay. What about the issue of shortages? I think you touched on this, Dr. Monto. There's been a suggestion that maybe we should be very careful with this, but other countries are using the drugs very widely.
That's very true. In Japan, it's standard of care to treat all children who have H1N1 infection. The UK has a very large stockpile. In fact, this past spring, during the first wave, they were using extensive amounts of drug in prophylaxis. We're a little concerned about using drug in prophylaxis right now because of the possibility of resistance, which I don't think is going to be a big deal, but also because it burns through large quantities of drugs. And this will disappear as an issue as more vaccine is available.
So there's one other point to make, and that is, as we look at what's available in the stockpile, there is neuraminidase inhibitors that can be administered to the American public. That's not a problem. Where we do have a problem is the suspension that we give to little children. And that's where there is a shortfall of the suspension, and many pharmacies are having to compound or make from capsules drug that we can give to children. This should be rectified within the next 2 to 3 weeks, but we are in a window where we're having to be creative and compound drug for young children.
I see. Are there other aspects of this? Is it just antivirals, or what about vaccine? Are we seeing reluctance to get vaccine aside from the obvious? The thing we know that it's difficult to get.
Yes. This is a bit of a paradox because this vaccine is just like seasonal vaccine, except it's got less in it, because seasonal vaccine typically has 3 components. This just has 1 component. It's just like the vaccines we've been giving for 40-odd years, and therefore it is not a new vaccine, and there shouldn't be any reluctance to get it on the basis of its being less tested than the regular seasonal vaccine. If anything, it's been more tested than the standard seasonal vaccine. It's actually, the novel H1N1 is actually in the formulation for the southern hemisphere. They're going to need winter vaccine in our summer of 2010. And it's actually in the trivalent vaccine for seasonal use. And therefore, I just don't understand this concern about a vaccine which is under-tested.
There's one other point to make about the vaccine, and that is there have been some physicians in the United States who have said you should not take this vaccine because it has an adjuvant in it. We need to dispel that rumor immediately. There is no adjuvant in the vaccine that's going to be available in the United States.
That's an important point. There is a lot of misinformation about the vaccine. And I'm wondering, because you say that there are some doctors who believe there is an adjuvant, how, and the safety issue, the CDC has made the point, the drug companies have made the point, the National Institute of Allergy and Infectious Diseases has made that point. Is that message actually getting to the frontline doctors, the people guys out there practicing in their offices?
Probably not. Because there's a lot of confusion about influenza vaccine. It's the only vaccine we have that's reformulated every year, and we always have concerns about mismatches and things like that. So there is a lot of uncertainty about the influenza vaccine. I think we shouldn't come down too hard on the issue of adjuvants. What this means is that the vaccine has been as well tested or better tested than our regular seasonal vaccine, but we may be using adjuvanted vaccines in the future. Most of the rest of the world is right now. We're going to have a lot of safety information, and we may find that we're going to have a better vaccine for older individuals, for various age groups, where the flu vaccine hasn't performed as well as we would like. But this is the future, and right now we can say that this is a very safe, well-tested vaccine.
That's an excellent point, Arnold, because adjuvanted vaccines have been evaluated worldwide except in the U.S., and we'll learn from the safety experience globally.
Mm-hmm. One last word, each of you. Dr. Whitley?
Well, influenza is a huge problem in the United States today. Fortunately, we do have antivirals that are effective in therapy, and they should be used until we can immunize as many people in the population as we can. I think Arnold and I both look forward to when vaccine becomes available so we can take care of high-risk individuals first.
And we just have to remember, when the dust settles and the pandemic is finished, that a pandemic occurs very infrequently. Shouldn't be go to sleep because about this one, because there was one interval between pandemics of about 11 years. So we may have another pandemic in the foreseeable future, but seasonal flu kills. And we just have to keep in mind, when the dust settles and we're all happy that we've handled this pandemic well, that we need to continue to be concerned about flu. This is particularly true in the developing countries, where only pandemics are recognized because they have so many other problems. And they want vaccine for pandemics, but nobody is going to be making vaccines if they're only going to be used very infrequently. So we've got to keep this in mind and work on this on a global basis in terms of total influenza control.
Thank you both, gentlemen. In Philadelphia, I'm Michael Smith, MedPage Today.